All right, good morning, everybody. Welcome to PT on Ice weekly show. My name is Jessica Davis, and I am the head faculty for the Performing Arts Division, and I also teach the spinal management, the cervical and lumbar management courses. So welcome. I'm coming to you from Pittsburgh. Happy Tuesday. It's a little bit gray out here, but not bad for the summer. It's okay. So today, what we're going to talk about, hi, everybody. Oh, good. People are coming on. Okay, so today our topic of the day is going to be Maigne syndrome. So the reason I went on with this topic was actually it was a request by one of the participants in one of the courses. So on that note, if you have ever a topic of interest or something that you want us as ICE faculty to cover, let us know, because I thought it was a great idea, and I certainly didn't mind going over this topic because I learned just as much from looking this stuff up as I think that you will from me giving this. So Maigne syndrome was first described by Maigne in 1974. So he talked about T12 as a transitional segment, having characteristics of both a lumbar spine element as well as thoracic spine. And we know when we observe patients moving that this is an area where there's a lot of repetitive motion, especially with rotation. So he described that as a result of this, because there's so much movement, that patients often have symptoms in this region, but the precarious part, or the interesting part about this, is that it will not often appear as a symptom right along that segment. So this is also known as the Dorsal Ramus syndrome or Thoracolumbar syndrome. So if you look it up and you're doing some research, you can find it under those particular names. So the mechanism of injury of this area is often brought on by a twisting of the trunk or an extension type movement. And they'll typically, in an acute situation, they're going to report that they have a poor ache, localized ache over the iliac crest, and they will describe that they have pain with rotational movements. It also, in a chronic situation, and as we know with any chronic condition, it can be a little bit more difficult to diagnose. So in a chronic situation, they're also going to report pain with twisting. One of the variables that Maigne described that differentiates, he said, comparing it to lumbar spine type symptoms, was that patients will describe that they have an intolerance to laying supine. So if you have a patient that describes pain with rotation, pain along that iliac crest region, and they also tell you, I cannot lay supine, it actually makes my symptoms worse. So that's something that he talked about. So the issue here is the lateral branch of the dorsal ramus passes along the facet, and then it becomes subcutaneous several segments below, and it penetrates the lumbar fascia and the subcutaneous tissues. So Maigne described, I see, I don't know how to do that, sorry. I'm not very good with my technology, so I'm not sure what I'm supposed to do with that tapping, so I'm gonna ignore that, but anyway. So he talked about this, the Kibler fold test. So I'm going to show you in a minute what the Kibler fold test is. And so he would fold the tissue, and if the patient was symptomatic along that, in addition to reporting they had pain in the iliac crest or they had pain with rotation and intolerance to laying supine, that was another way of differentially diagnosing this area. So when I looked at the literature with this, so there's a lot of case studies done, but unfortunately, that's the most of what we have in terms of research. So I wanted to go along the symptoms that they reported in the case studies that I read. So they described a unilateral vague pain radiating to the iliac crest, an intolerance to laying supine, limitations in lumbar flexion and rotation. One of the comparable signs that they described was pain, or a reproduction of the comparable sign with passive intervertebral motion along the T12, even T9, T10, T11, T12, and L1. So if you're doing your PAs and UPAs and intervertebral motion, that will reproduce it. They also described that patients can have pain in the groin or testicular pain. And this was described in 2013 that some of these patients also report irritable bowel symptoms. So you can imagine, especially if this patient's having a chronic condition and they may not end up in our facility, and they may be reporting irritable bowel syndrome. So one of the case studies that was interesting was by an article by Kim in 2013, and he talked about a case with a 42-year-old woman who had osteogenesis imperfecta. Now, in that case, because of the osteogenesis imperfecta, they were unable to do any manipulation, obviously, to this patient, but what they ended up doing is an epidural block to that particular region, and that eased her symptoms. So again, it helps with that differential diagnosis of this region, what we do. So the most frequent presentation, however, of this syndrome is low back pain. So that's where we have to be very adamant when we're doing our differential diagnosis that we're considering, as we talk about in the ICE courses that you'll take, when you're considering this region, you've got to consider above. So Jeff will often talk about that T8 segment being kind of a great differential level for if you're going T8 and above for cervical spine type complaints or upper extremity complaints, or below the level of T8. So Maigne syndrome would be something that you would pick up on if you're using your good differential diagnosis and truly assessing all of those regions and considering that. So some of the other things that they reported was abdominal pain. And this was interesting too, because I've had cases where, and I've had other colleagues that have told me this as well, that they've had patients that have been diagnosed with greater trochanteric bursitis, and they were able to reproduce their bursitis symptoms, right, with unilateral application PAs over that T12 segment, pain over the hip, and pain over the pubis region. So it's important when we're considering that, that we're looking at all of those different comparable signs, and we're looking for reproducing their exact complaint, right? We're always looking for reproducing their exact complaint. And so one of the other things that is important to differentiate with this particular syndrome is it will be unilateral. So when you're evaluating, you're doing your body diagram, and I always talk about the body diagram because it helped me so much clinically, was when you're doing your body diagram, being very specific about the location of symptoms, right? And so they will describe this unilateral symptoms across that iliac crest down into the lateral hip, into the groin, into the testicle. So all of those regions could be influenced by this. And then I found the most recent study I wanted to talk about was by Kozera in 2017. They talked about the dorsal ramus mediated low back pain. And they described that it will present unilaterally in T11, 12, L1, L2, triggered with extension and or rotation. They said that it can radiate towards the gluteal area, posterior iliac crest, and then they emphasized it does not cross midline. And then they talked about how, depending on what part of the spinal nerve is aggravated, that it could affect both the posterior branches, the anterior branches. So that's where we're going to find those vague type symptoms. And it can cause, this is interesting, pseudo-visceral pain in the hypogastric area, false sciatic neuralgia, tenderness over the pubic symphysis, and hypersensitivity of the intestines. So I found that pretty interesting and also kind of correlating with what I already brought up. But they also said that the treatment for this they recommended was manipulation to the thoracolumbar region. And if the patient cannot have manipulation to this region, in the case as we talked about in the Kim article in 2013, doing a nerve block in that region if the patient cannot is not a candidate for manual therapy, right? So I want to show you what Maigne was talking about with the manipulation and also the palpation and the Kibler fold test. So I'm bringing my phone over here. Come with me. Okay, and I'm going to rotate this because I have Alyssa, who's amazing here. Hi. Hi. Okay, so Alyssa, I'm going to have you lay on your stomach. Okay, so she's going to lay on her stomach. So the way that Maigne described palpating this region, he suggested having the patient have their legs over, and I want you to relax right here. Good. Okay, so she's going to be over the table in this region. And then I'm going to get really tricky with my filming here. Okay, so when the patient's here, that's when we're going to go into and find our segments, right? So we're going to come up into the thoracic spine, and we're going to do, and pardon my imperfect hands here because I'm holding the phone simultaneously as I do this, but that's where we're going to be doing our central PAs all the way down. And then we're gonna also come across, if she was reporting that she's having some iliac crest discomfort or some lateral hip pain or buttock pain, then we would also want to include our UPAs to this region, right? So what are we looking for when we do this? We're looking for a reproduction of their exact complaint. So if we're getting vague symptoms or local tenderness, but it's not reproducing what they're describing, that's something that we need to consider. And when we're shuffling our hypothesis list, when we're doing our objective part of the examination. Now the Kibler fold test, so because as I talked about, the nerve distribution, how it can influence the soft tissue components, the Kibler fold test is you take the soft tissue and you create a fold and you would roll along. And so what the patient would say is, that's reproducing what they're describing, right? There's sensitivity, they would report sensitivity in this region. So in most patients they're not gonna have that sensitivity, but in cases of Maigne, they will report sensitivity with this Kibler fold test. Okay, so that's that. And then what I also wanted to show you, come on up, Melissa. So other areas, so other ways that we are gonna just treat it, we can also have patients, in side lying, and we can work on our passive intervertebral motion, right? Getting them and working on that region in side lying. But also I wanted to review the mobilization technique to the thoracolumbar junction. So you guys can see me here. Okay, so for here, listen, yeah, you're gonna long sit. Okay, and you're gonna come close to me on this one. Okay, so this is just a nice technique, and we review this again. You're gonna have this in the lumbar management courses, and also Justin Dunaway's course. Again, so I'm just reviewing it with you guys, but I highly encourage everybody attending these courses because you'll learn this amazing technique. Okay, so you're gonna put your hands behind here. So this is just a nice technique. You come up along the patient here and you kind of give them a hug, and you're probably not gonna hear me too well from this perspective, but what I'm gonna do, I'm gonna have her trunk flex. I'm gonna stay close, and I'm gonna have my hands and fists right at that thoracolumbar junction. And I'm gonna have my legs strategically placed so that I can walk my patient, literally walk her down and go right into that segment. Good job, Lisa. Okay, so those are different strategies, but of course you're gonna wanna come up with your impairment list, the things that you find in that patient, and address them. So whatever you're discovering, whether it's hypomobility, weakness, anything, but what I wanted to review, hopefully this is a helpful in terms of giving you an idea of what is Maigne syndrome, how am I going to identify it. So anytime you have a patient who has these vague type symptoms, pain with rotation or extension or flexion in some cases, even abdominal complaints or irritable bowel, interestingly. So consider this. Okay, so I hope that was helpful, and have a wonderful Tuesday, everybody. Hopefully some of you have sunshine, unlike me, and enjoy your summer, and it's been awesome to chat with you again. So have a great week, everybody.